This is the Week 9 coursework for 134, beginning Chapter 5 on anesthetic monitoring. And remember, it truly is true that diligence is the mother of all good fortune. Or another way of saying, we make our own luck. As we start the process of learning about monitoring anesthetic patients, we're going to be aware that one of the most important things we have to monitor are the patient's vital signs. And the vital signs we'll be looking at are the body's response to anesthesia. Anesthetics, either for surgical procedures or dentals or diagnostic procedures, are going to affect the patient's body. It's going to affect the body systems. And the things we have to pay particular attention to are going to be our heart rate, the heart rhythm, the respiratory rate and the respiratory depth, the patient's mucous membrane color, capillary refill time, pulse strength, the blood pressure, and the patient's body temperature. Now we're going to pay attention to a whole bunch of stuff as we go through, but vital signs are where we're going to begin, and those are an extremely good indicator of how the patient is doing or how the patient is not doing. We will also monitor the patient's reflexes in an effort to give us an indication of where that patient is, stage, plane of anesthesia. Reflexes are, as you're probably aware by now, involuntary responses to a stimulus. Things we will commonly monitor will be palpebral, the corneal reflex, pedal reflex, swallowing reflex, laryngeal reflex, and papillary light reflexes. Plus, I want to give you a couple others in there that aren't in the book but are real good indicators as well. All of these, plus a few other things, are indicators of our anesthetic depth. We are, in fact, when we monitor patients, monitoring two separate yet interrelated things. We are measuring by using vital signs and physiological parameters how that patient is doing physiologically. By monitoring reflexes, we're going to monitor how that patient is doing as far as stage and plane of anesthesia. As a general rule, the deeper they go, the less they're going to do physiologically. However, that is not something that you can take for granted. You need to measure physiological status, you need to measure depth, stage, and plane of anesthesia, and then you need to correlate those two and make sure they make sense. Okay? So you've got to use your thinking cap on some of this stuff. The parameters are going to offer predictable responses to anesthesia at various depths. As a general rule, the deeper they go, the more the reflexes will be depressed. The reflexes, however, may be affected by the drugs that are on board or drugs that may have been administered beforehand, drugs that may be on as a part of working on a disease process, an active disease, or individual response variation. Not every patient is the same. We are going to monitor that anesthetized patient as often as possible. Continuously is ideal. It's pretty much mandatory if you're really going to be doing a good job. Generally, I try to set students up on a 5-minute cycle. 5-minute cycle of measuring vitals, 5-minute cycle of reflexes, 5-minute cycle of checking machines and what's going on, 5 minutes of making sure we have a ventilation, and then at the end of that 5-minute cycle, it's time to do it all over again, having included in there writing all the things that you found in the anesthetic record. Stages and planes of anesthesia. We need to learn where patients are in stages and plane of anesthesia so we do not either under-anesthetize or over-anesthetize any given patient. There are, by common convention, 4 stages of anesthesia. 1, 2, 3, 4, written in Roman numerals. Stage 3 is divided into, in this book, 4 planes. Generally, I divide into 3. That's just me. You'll see some authors use 4 planes. You'll see some authors use 3 planes. We're pretty much on the same plane, excuse me, for how we divide those regardless of 3 or 4. Planes are usually written with a regular Arabic numeral. From stage 1 through stage 4, there's a progressive decrease. We're getting deeper, and there is less pain perception, there is less motor coordination, there is less consciousness, There are fewer reflex responses, muscle tone becomes increasingly flaccid, and cardiopulmonary function is depressed. The deeper they go, the bigger toll it's taking on the body. We start off stage 1. Stage 1 begins or is characterized by being the period of voluntary movement. Patient sitting on the table, panting their little head off, being nervous, scared, unhappy. At this point, we start to administer often a intravenous anesthetic to induce anesthesia, and the patient begins to lose consciousness. The stage will end with a loss of the ability to stand, and the patient will go into lateral or sternal recumbency. This stage, stage 1, is characterized by fear. They don't like what's going on. Excitement. They want to run away. Disorientation. That will be due to the pre-anesthetics or possibly to the induction drug. They may struggle trying to run away. They may urinate and defecate because they don't really like this stuff, okay? And you'll find, if you're measuring their physiological parameters, an increased heart rate and an increased respiratory rate. They are scared. We're having a predominance of sympathetic nervous system signs. They're just not happy about being there. Now, some of them are as calm and as happy as they can be, but a lot of them really aren't fond of this particular process. Stage 2. This is the period of involuntary movement, often the excitement stage. If you try to get them through stage 2 as quickly and as expediently as possible, go from stage 1 to stage 3 and really avoid all the problems of stage 2. It is often characterized by irregular breathing, which may include apnea. They vocalize, they struggle, they paddle, okay? They look like they're having a seizure. You'll get an increased heart rate, increased respiratory rate. If you look at them, their pupils are dilated wide open. They have a lot of muscle tone, and they have plenty of reflexes. They may still, in some cases, try to run away. Their actions, however, are not under conscious control. This is all an unconscious process. The stage will finally end when we get to stage 3. We'll get some muscle relaxation. We'll have a more regular respiratory rate. We're going to have decreased reflex activity. Muscles will start to relax. And usually what will happen then is if they are struggling, paddling, screaming their little heads off, they'll quit that, and then they will start to act like happy animals again, especially since they're sound asleep. Stage 3 we refer to as a period of surgical anesthesia, realizing that that can be divided into 4 planes. Okay? Stage 3, plane 1, is not adequate for what you and I would refer to as surgery. There is a regular respiratory pattern. They are not having voluntary limb movements. There is no voluntary muscular activity. The eyeballs start to rotate ventrally. Pupils by then are partially constricted. You get a decreased pupillary light reflex. The endotracheal tube may be passed and connected to the gas anesthesia machine. The reason we get to stage 3, plane 1, is to get a tube in them, get them on gas, and start keeping them on the downward little flow towards where we're going to be doing surgery. Other reflexes are still present, but decreased. What you're going to see on these guys, there's going to be a lot of muscle tension. In some cases, there's going to be they still have pretty good jaw tension. They may, if you try to pass it in a tracheal tube, you may or may not have laryngeal spasms, but you can usually get a tube in. They're going to have a good palpebral reflex, and their respiration is going to be thoracic. They're going to be breathing with their chest. They're not going to be breathing with their abdomen. If we are diligent, we provide adequate amounts of inhalants. If we provide them some positive pressure ventilations, we're going to get them down to stage 3, plane 2. And this is going to be, suitable depth for most surgical procedures. It's going to be suitable for spays, neuters, some minor orthopedics, and that kind of stuff. It's going to be characterized by regular and shallow respiration with a decreased respiratory rate. They're not going to breathe as much, and they are not going to breathe as deeply. You're going to find their respirations at this point are going to start to transition from thoracic respirations to more abdominal respirations. Their chest isn't going to move as much or with as much force, but they're going to start to really work with their abdomen to provide ventilations. When we get to about end of 3.2 or early 3.3, they're going to be about 50-50 thoracic respirations and about 50-50 abdominal respirations. Blood pressure and the heart rate will mildly be decreased. We're going to have pretty good muscle tone. Okay, they're going to relax so we can do those procedures. They're going to have pedal and swallowing reflexes are absent. Okay, you squeeze on their foot, they're probably going to not mess with it. Swallowing reflexes are not trying to spit the tube back out. And you'll find if you start tapping on the medial canthus of the eye, they're still going to may have a little bit of palpebral reflex, but not that much, if at all. And the eye is going to rotate ventro and medial. If we have a patient in stage 3 plane 2, if we stimulate them surgically, okay, make that incision, go through the skin, go through the subcutaneous tissue, go through the linea alba into the peritoneum, we will probably have an increase in heart rate. Blood pressure will go up, and they may respire more. The patient remains unconscious, but they're not going to be struggling. If they're struggling, they're not in 3-2. Light pupillary light response is sluggish, so if you're shining lights in their eyes, their pupils are probably just about done, and the pupil size is going to be moderate. Generally, we're not doing that. Okay, it's kind of silly when you've got everything going to be looking pupillary light responses, and I don't place much stock in them. Some people do, but if you want to, that's fine. That's what you're going to see. Stage 3, plane 3. Really is, in most books, in my book, pretty deep. And for most things that we do, it is going to be too deep. Okay, if you get to 3-3 for spays and knitters, you've probably gone too far. You're going to find a pretty low heart rate. Respiration, you're going to have a low tidal volume. They're barely moving that bag. Your respiratory rate's going to be way down. Okay, your pulses, if you've been following your pulses, you're going to find that those get pretty weak. Okay, the pulses are getting pretty thin. Your capillary refill time is going to start to increase, okay, because of difference between systolic and diastolic pressures. There's going to be poor to absent papillary light reflex, central eyeballs. You have moderately dilated pupils. Any reflexes are pretty much gone. Palpebral is gone. Muscle tone is very relaxed, very flaccid. And if you're watching respirations again, the pattern of respiration, by 3-3, you'll find the patient is breathing almost exclusively with their abdominal muscles. You have paralyzed the thoracic muscles and even some of the diaphragm. And now the only way they can try to respire is by using abdominal musculature. If you get a patient down to the point where they're using just abdominal muscles and very little thoracic muscles to breathe, you've probably gone too far on that guy, unless you're doing something that I have no real concept of. Stage 3, plane 4, this is early, and some might say moderate, anesthetic overdose. No reason for a patient to be in stage 3, plane 4. By then, you've got all abdominal breathing, and even that is starting to go away. They're just not breathing. You're going to have fully dilated pupils. The eyes are going to be dry as a bone. Any and all reflexes are long gone. You've got a huge depression of the cardiovascular system. You've got these really, really pale mucous membranes. All the muscles are just as flaccid as they can be. These guys are on the verge of death. Okay, if you get to stage 3, plane 4, somebody has seriously messed up along the way. There is no reason to be here unless you're on your way to a purposeful euthanasia. Finally, we get stage 4. This is anesthetic overdose. And really, as I often refer to it, they are down, they are deep, and they are dying. 3 Ds. They are way down, they are way too deep, and they are dying. They are on the verge of death. They have no respiration. They have complete cardiovascular response. At this point, they may not even have a heartbeat. Death is imminent. And at that point, you've got to do something to immediately resuscitate the patient. I've seen this a couple of times. The worst case, I think, was in a procedure. Student wasn't paying attention. It was time to wake the patient up. We said, okay, now you can turn them off. Turn the vaporizer off. Okay, and the student, not paying attention because she was watching something else, turned it from, instead of going to 0 or to off, turned it to 5%. And the dog just kept going deeper and deeper and deeper, and frankly, we started wondering what was going on. Dog got to stage 4, was on the verge of death because the vaporizer was set at 5%. Wasn't paying attention. So, stage 4, bad stuff. got no reason to be in stage 4, and unless of course you're really trying to kill them. The nomenclature system, I prefer actually. Stage 3 is divided into 3 planes. I find it more usually easily understandable by student, and I think it just makes more sense. Stage 3, plane 1 is light. Stage 2 is medium, and stage 3 is deep. And so if we're in stage 1, stage 3, plane 1, the only thing we're going to use in light is maybe a skin suture, or a little bit of a trauma that we're going to sew up real quick. If we get to 3-2, that's where almost everything is done. Okay, even orthopedics. Stage 3, really, that's too deep. So, I do stage 3, 1, 2, 3. Your author does stage 3 and 4. It's, as long as you know where you are, you can get to where you need to be. You might want to write that down. That was pretty good. If you know where you are, then you can know where you need to be. That's pretty good. I think I'll write that one down myself. Of course, the objectives of surgical anesthesia, why we're doing this. Number 1, the patient shouldn't move. Okay, it's hard to do surgery on patients that are running around the room. Just doesn't go well. The patient isn't aware. They should be unconscious. They should not know that they're having a procedure. They should wake up with no memory of the procedure. They should just simply go to sleep, wake up, gosh darn, wonder what happened, took a little nap. And finally, and perhaps the most important part of it, the patient doesn't feel pain. Okay, there should be no pain associated. We use preemptive analgesia. Patient goes in analgesic. Patient wakes up as analgesic as possible. There is no way to take away 100% of pain, but we can at least ameliorate it to the point where it is as tolerable as possible. No pain. As we assess patients during surgery, we are going to assess vital signs using the single most important tool you have, which is you. You're going to use your touch. You're going to use your hearing. You're going to use your vision. You're going to use your nose. Most importantly, you're going to use your brain. Okay? If you don't have a brain, get one. It will come in real handy in monitoring patients. We also will use mechanical instruments. You can't fly a plane without the instruments. Okay? And they come in real handy. Take them with a grain of salt, but instruments are good. That includes an ECG, a blood pressure monitor, a capnograph, Doppler, pulse oximeter. You probably will not have all of these in your practice, but what you do have, you need to use properly and professionally and diligently. We generally monitor patients around groups or body systems. For example, circulation. When we look at circulation in that patient, we want to know their heart rate. We want to know their heart rhythm. We need to assess their pulse strength. We're going to check their capillary refill time. We're going to check their mucous membrane color. And either directly or indirectly, we should be monitoring blood pressure. That's all going to give us a big clue on circulation. Oxygenation, which is the integration of circulation and ventilation. For oxygenation, we're going to look at mucous membrane color, capillary refill time, hemoglobin saturation, there's your pulse oximeter, inspired oxygen, arterial blood oxygen, okay? And for ventilation, we want to check respiratory rate and depth, breath sounds, you ought to listen to these guys, expired CO2 levels, here's our capnograph, arterial carbon dioxide. If you got a blood machine, you can check arterial carbon dioxide, arterial oxygen, and blood pH. So we're going to use as much instruments as possible to check for all these parameters to make sure the circulatory system, the heart and vessels are in good shape. The ventilation is good, and if the heart and the ventilation are working together, how is the oxygenation of this patient? One thing on oxygenation, look at the tongue. Okay, the tongue is really one of the best indicators of oxygenation. If the tongue is nice and bright and pink and healthy and moist, things are going good. If it starts to turn blue, that's a bad sign. Look at the tongue. Tongue's a good sign. From the American Academy of Veterinary Anesthesiologists, Guidelines 2009, here's something good. Continuous awareness of heart rate and rhythm during anesthesia, along with the gross assessment of peripheral perfusion, which would include pulse quality, mucous membrane color, capillary fill, are mandatory. Arterial blood pressure And the electrocardiograph should also be monitored. There may be some situations where these may be temporarily impractical, such as moving of an anesthetized patient to a different area of the hospital, going from prep into surgery, yada, yada, yada. But you are going to do it as often and as meticulously as you can. Monitor, monitor, monitor. If you're in doubt about what to do, monitor some more. If you get through monitoring some more, then monitor some more. Attention, attention, attention. Indicators of circulation. We'll go through these in some detail. Heart rate. Okay? We can assess these physically, i.e. you do it by palpation of the apical pulse through the thoracic wall. Put your hand across the chest. Do you feel a heartbeat? Palpation of the peripheral pulse. Femoral artery. In large animals, there are other places we can do it, like the submaxillary artery. Find an artery, feel a pulse. We can auscultate with a stethoscope. Okay, this is harder in recumbent anesthetized animals. This is why an esophageal stethoscope is such a wonderful thing. But yeah, we want to listen. Do we hear a heartbeat? Lub-dub, lub-dub, lub-dub. We can use mechanical instruments to help assess the heart rate. The ECG machine, a blood pressure monitor, okay, the Doppler or an oscillometric monitor will give you that as well. An intra-arterial line, if we can put an eye line in this thing and use direct arterial monitoring with a transducer, that will give us the heart rate. If we end up with a patient that is bradycardic, heart rate way too slow, number one, it can be the depressive effect in most anesthetics. We may just be too deep, okay? Or we may have used drugs that were bradycardic and we didn't use an anticholinergic to keep that heart rate up. The alpha-2 agonists especially cause bradycardia, opioids to a lesser degree. Excessive anesthetic depth certainly has got to be a consideration, and possibly adverse effect of other drugs. Sometimes you can get some paradoxical effects. The drugs that should probably speed the heart up can actually cause a bradycardia. You got to know what you're doing, and if you have a bradycardia, figure out what's going on. Are they too deep? Is it the alpha-2? What's going on? And once you understand, then you can correct it. But keep a bottle of glycopyrrolate in your pocket. If we have a tachycardia, okay, maybe due to anticholinergics, okay, could be due to our old friend the cyclohexamines, man, a little too much ketamine in there. Could be to inadequate anesthetic depth. They just may be too light. Pain speeds up the heart. Lack of blood pressure will speed up the heart. Blood loss and shock will speed up the heart. And then hypoxemia and hypercapnia will speed up the heart. Heart's trying to pump more to get more oxygen in, blow off more of that CO2. Tachycardia can be caused by many different things. Heart rhythm should be assessed along with the heart rate. It's not just enough to know if the heart is at what rate the heart is beating. We need to know the quality and character of the heartbeat itself. We can have a normal sinus rhythm versus sinus arrhythmias, and both can be seen in anesthetized animals. If there is a question about blocks, say a first or second degree block, we're going to use an electrocardiograph, okay? And uses of electrocardiograph can be very, very good. They will give you good indicators of heart rate and heart rhythm, okay? But don't take them for much more than that. But for that, they're excellent. Causes of arrhythmias. Many things can cause arrhythmias. Example, drugs. Anticholinergics, alpha-2 agonists, the barbiturates, the cyclohexamines, all can predispose to arrhythmias. There can be problems with diseases, concurrent diseases, okay? Hypoxemia, hypercarbia, heart diseases, some of these old congestive heart failure dogs, trauma, gastric dilatation volvulus, the GDVs. Oh man, the GDVs are a one-way trip to arrhythmias. All that can predispose towards a heart arrhythmia, and you're going to pick that up watching your EKG. One of the best monitoring devices you can have is an esophageal stethoscope. If you don't have one, lobby hard to get one. If you get used to using them, you're going to love them. It's a thin, flexible tube attached to an audio monitor. You can use a regular stethoscope. You can hook them up to radios. You can hear these things across a room. What it does is it electronically amplifies the heart sound. You pass the tube, it goes down to the esophagus, you position it right across the base of the heart, and you can hear that heart like it was in your head. Okay? It's to the level of the fifth rib. You get it about there, and then you wiggle it back and forth. You found the loudest spot, and there you go. It gives you heart quality, it gives you heart rate, blub dub, blub dub, blub dub, and you can hear respirations remarkably good. If you want to monitor respirations, just put in an esophageal stethoscope. You'll hear it like it was Beethoven's Fifth Symphony. Okay? They're cheap, they are reliable. The batteries don't go out. I mean, you can put an esophageal stethoscope down a patient, stick one of the ends of stethoscope in an ear, have one ear open, and it's always going. It's a great little tool, and they're cheap. Electrocardiographs, almost everybody has an EKG. It's a graphic representation of the electrical activity of the heart, PQRST. It's used to detect arrhythmias, which are very common in anesthetized animals. If you don't see arrhythmias, then you start to worry. And it will help differentiate from normal and dangerous rhythms, life-threatening rhythms, from the ones that you just get that you expect that aren't any big deal. But you don't know that unless you're looking. You can't see what you don't look for. There is a little cheap esophageal stethoscope hooked up to that little monitor. Costs next to nothing. Okay, put batteries in it. Some of them plug in. Pass that esophageal stethoscope. See that poor golden retriever on the right? Pass that down after they are anesthetized. Use a little KY lube. Get it down over the heart. Hook it up to that machine, and you'll hear lub dub, lub dub, lub dub, lub dub, and then you'll hear as they breathe. Great stuff. Cheap. Good information. Last week we went over the heart and the various aspects of the heart and the cardiac conduction system. Your book has a review on that, so this should make sense. Start off with the SA node. The SA node sends these wonderful impulses throughout the atria, goes down to the AV bundle, and then down the bundle of His. From there it goes down the right and left bundle branches, turns up, goes through the walls of the myocardium, into the Purkinje fibers, and stimulates the ventricles to beat. The heart beats from the top down and the bottom up. You should be aware of and know the parts of an ECG now: the P wave, the PR interval, the QRS complex, the ST segment, and the T wave. Okay, various examples of recordings, even though the waves and the waveforms may appear a little different depending on species, depending on positioning, depending on even how you set up your ECGs. You should have P waves. You should have a QRS interval. You should have an ST segment. You should have an QRS complex, T wave. All the sections, all the waves, all the intervals should be consistent throughout an ECG for all species, unless you have some problems. Your book goes through and describes several common cardiac arrhythmias. You need to be aware of these. You need to be able to recognize them as much as possible. Understanding you don't have to be perfect yet, but you need to start getting at least some of this down. Begin with sinus arrhythmia. A sinus arrhythmia is an arrhythmia where the heart rate is coordinated with respirations. Okay? This is normal in dogs, horses, and cattle. There is a decrease. The heart seems to skip a beat when the dog inspires, and then it goes back to normal when the dog exhales. And the ECG will seem to go lub dub, lub dub, lub dub, lub dub, lub dub, lub dub, lub dub. Seems to skip a beat. And you will see that that happens every time they take a breath. Okay, perfectly normal dogs, horses, and cattle. It should not happen in cats and people. Okay, if you're doing this, you might want to see your doctor real quick. Or cats, that needs to be brought to somebody's attention. But these respiratory arrhythmias are normal in those species. Kind of scare students at first. We kind of talked about these before. Sinus bradycardia. Okay, it's sinus because it's come from the SA node. Bradycardia because there's a slow heart rate. Common during anesthesia. We just depressed this guy. There can be due to excessive anesthetic depth, drug reactions. Okay, we can use reversal agents. We can simply lighten the patient up some. We can give them anticholinergics. Keep the glyco in your pocket. that helps alleviate that. A sinus tachycardia, again, is coming from the SA node, fast heart. It can be simply inadequate anesthetic depth. Some of these guys will seem to play possum on you. When you cut on them, they sit up, they look at you and go, whoa, that hurt. Drug reactions, surgical stimulation, you figure out why the heart's too fast, what's going on, and then you treat that. Almost always, in my experience, it's going to be due to inadequate anesthetic depth. Somebody wasn't bagging their patient like they should have been. Here's a strip from an ECG showing a sinus arrhythmia. If you follow along, PQRST, PQRST, PQRS2, 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 long flat place. Took a breath. PQRST, PQRS2, flat place. Took a breath. PQRST, PQRST, flat place. Took a rest. When you see those flat places, when you see that like it skips a beat or two, that's a sinus arrhythmia. Dogs, horses, cows, perfectly normal. If this is a cat, I'm starting to get a little nervous. AV blocks, and we find quite a few AV blocks. In fact, AV blocks are actually normal in horses. If they don't have AV blocks, it's kind of a problem. AV block is there's a delay or interruption of the electrical impulse through the AV node. Goes from the SA node, hits the AV node, and just gets blocked. Okay? There is a first degree AV block where it just is delayed, okay, but it goes on through, kind of like traffic on Friday afternoon. Second degree AV block is where there is an occasional missing QRS complex. Some of them get through, some of them don't. And you may have, a P wave, no QRS. Third degree AV blocks is where the atria and the ventricles are contracting completely independently. Okay, the ventricles in most cases, if they don't get an impulse from the AV node, from the SA node, they will just go ahead and beat on their own. They'll pick it up. But you will commonly see the atria and the ventricles with third degree AV block just kind of independent of each other, not paying any attention, kind of like a bunch of third graders on a field trip, not listening to anybody, running amok. And you'll get very randomly irregular PR intervals. This will jump out at you and show you that. Here's some strips from the book, ECG tracings. I'm not going to ask you to identify these, okay? I won't have ECG strips on the test, but I do think it helps to look at them. These are straight out of your book. Figure 575859 shows first degree AV block, second degree AV block, and then if you get down there to that third one, you start seeing that on a ECG tracing on a patient, and you're going to start to get nervous. I'd just scare the bejeebers out of me. But yeah, that's what they look like. You can compare them within the book and go through and see the various types of AV block. First, second, third degree. We can get premature complexes. Complexes are runs of electrical activity that occur too early in the cardiac cycle. One of the common ones is supraventricular premature complexes, often abbreviated SPC. In this, we get one or more normal QRS complexes closely following the previous QRS complex. And they give you a couple of examples there without adequate amount of rest between QRSs. They seem to start coming much too fast. Okay, the ventricles are starting to beat too quick, out of rhythm with the atria and out of rhythm with the entire cardiac cycle. Supraventricular complexes, not good. Supraventricular tachycardia is when we have a series of 3 or more SPCs in a row. Okay, this is getting more serious as we go. Ventricular premature complexes, VPCs, instead of SPCs, VPCs. We get one or more wide, bizarre, and if you look at that tracing, they look pretty bizarre, QRS complexes closely following the previous QRS complex. And if you look at that tracing, you can see right there towards the end, a lot of that run of those really strange looking QRS complexes. They are just not happy at all. That's figure 15-12 from your book. If you see that, I'm sure you're going to bring that to somebody's attention real quick, as well you should. Ventricular tachycardia is when we have a series of 3 or more VPCs in a row. And if you're getting that on an ECG, there's some people going to be wishing they wear Depends. Fibrillation. Fibrillation is about as close as you can get to dead without quite being there yet. VFib or AFib is not a big deal, but VFib is really, really bad. You can get into is a chaotic, uncoordinated, small muscle bundle contraction within the atria and or the ventricles. AFib, you see, and if you can look at that, you get a fine undulating baseline. You don't really get a P wave. You just get kind of like the P waves having a seizure. There is an absence of P waves. These guys, can show some degree of weakliness in there. You end up with a real tachycardia because it's going way too fast, and your normal QRS complexes are at irregular intervals. This one doesn't show as irregular as some you might get, but atrial fibrillation you can deal with. Okay, atrial fibrillation is undesirable, but it is not in the same class as ventricular fibrillation. VFib, that's VFib. That's just gobbledygook. Okay, you get this. It's just like you're drawing, like a third grader drawing on a piece of paper. There is no P wave. There's no QRS complexes. The ventricles are just fibrillating. They're just sitting there twitching like nobody's business. And as you would imagine, they can't pump blood. Okay, this is an acute, life-threatening. You're getting on the way to dying, and you're probably going to die anyway. Event on an ECG. You see VFib, you start treating with one hand, but you're yelling to the kennel person to get a bag with the other. PEAs, pulseless electrical activity, another really, really bad thing. We have a cessation of heart contractions, really bad thing, and or palpable pulses, lack of a pulse, bad thing, in the presence of normal or nearly normal ECG. So if you're just looking at your ECG, this thing looks fine, but you have no real heart contractions and you may not have a pulse. It is associated with cardiac arrest. Okay, the heart is not pumping. ECG measures the electrical activity of the heart. Okay, the heart can be at a perfect standstill, and the ECG can still keep going. In fact, sometimes if you monitor patients you have euthanized, and the patient may be on the table, you've euthanized them, they're spread with cancer everywhere or something, and you give them something, they're dead, heart stops, you may still get a normal EKG, and that can really get to you. You must do both physical monitoring and ECG monitoring. Just because that ECG is going doesn't mean the heart is. Feel a pulse, hear a heartbeat, make sure the heart is good. The patient and the machines must match up. The patients and the machine must make sense in light of each other. Some other indicators of circulation: capillary refill time. Again, I'm not a big fan of capillary refill time. It's something that you do, but you take it with a grain of salt. It is the rate of color return to the oral mucous membrane after application of gentle digital pressure. You squeeze on the gums. You take your finger off. You see how long it takes to go from pale back to red. It indicates peripheral tissue blood perfusion. In a way, that's true, but it's also an indicator of how long it takes when you exhaust that mucous membrane for the systolic and diastolic pressures to catch up to each other. Less than 2 seconds is prolonged and indicates poor perfusion, indicates a wide disparity between systolic and diastolic pressure. It can result from a whole bunch of things: epinephrine release, low blood pressure, hypothermia, cardiac failure, excessive anesthetic death, blood loss shock, bad breath, having your feet on the wrong legs, the day of the week, the phase of the moon, who's president, and what song is playing on the radio. If you see an abnormal capillary refill time, it tells you that something's wrong. Okay, something may be wrong. You need to check it out. Take it at that and don't go any further. It results in reduced temperature of affected parts. You're just not getting good perfusion there, so limbs will turn cold. From last week, you should know blood pressure is the force exerted by blood in arterial vessels, putting pressure and flowing against the wall of that vessel. What we need to do is evaluate tissue perfusion during anesthesia. That tissue perfusion is going to keep organs alive. Okay, if the organs aren't perfused, then they're going to have problems. That would include heart rate, stroke volume, vascular resistance, systemic vascular resistance, arterial compliance, blood volume. There are no commas in that. I just realized that. That's okay. But all those are going to be a part of blood pressure. Heart rate, stroke volume, vascular resistance, arterial compliance, blood volume, all of that is going to play a major role in blood pressure. Blood pressure is going to vary throughout the cardiac cycle. Okay, I mean, there's systolic, there's diastolic. Blood pressure is a wave, and it will go up and down throughout any given procedure in any given animal. And what we have to really watch for is hypotension and hypertension. In our profession, hypotension is more prevalent. It's going to be more of a consideration. In humans, hypertension is more of a problem, but we do see it. We do see it in veterinary medicine. From last week, you should understand what systolic pressure is. Systolic pressure is the pressure of blood produced by the contraction of the left ventricle, how much force is being produced on the blood. All blood pressure monitoring instruments can measure systolic pressure. Systolic pressure is one of your best indicators of how that heart's doing. Diastolic pressure is the pressure that remains in the arteries when the heart is in the resting phase between contractions. That's your low end of the blood pressure. Systolic, diastolic. And some, not all, blood pressure monitoring instruments can measure diastolic pressure. Most of them can these days. The newer, more modern ones can do that. If you're getting some older, reconditioned, I got it on the internet for $49.95 machines, they may not have that. It's really nice to know systolic and diastolic. It's better to know systolic than nothing. Mean arterial blood pressure, very important. You've got to know your mean arterial blood pressure. That is an average. It's actually a mathematical calculation between the cardiac cycle. It is the single best indicator of blood perfusion to internal organs. And most of the machines you're going to get are going to give you systolic, diastolic, and mean arterial pressure. Take systolic and diastolic with a grain of salt, but pay real attention to your mean arterial pressure. That mean arterial pressure is what's going to give you your best indicator of how perfusion's going at that point in time. Look at mean arterial pressure first. Pulse strength is another good thing to measure. Pulse strength is a good indicator of circulation. It can be a good indicator, a rough indicator, an approximate indicator of blood pressure. Okay? It is determined by the difference between systolic and diastolic blood pressures, the vessel diameter, and other factors. Okay, high blood pressures, decent systolic pressures, good vessel diameters, you're gonna have a good pulse. There's several places that you can measure it. Under the tongue, the dorsal pedal. Dorsal pedal is an especially good artery to measure. Femoral, the carotid, the facial artery in horses particularly, the ear, oral arteries in some species. Different arteries are appropriate for different species. For example, we're probably not going to do the femoral artery in a cow, but the dorsal pedal in dogs is great. Okay, just different ones for different species. Pulse strength is always going to go down in anesthetized animals. Just count on it. The deeper they go, worse the pulse strength. And it's always a subjective interpretation. I may feel a pulse and go, oh, yeah, that's pretty good. And you look at it and you go, oh, no, that's not so good. And I look at it when I say, oh, that's not so good. And you go, what are you talking about? That's good. There's a certain amount of subjectivity to it. So, if you feel it and if you're consistent, that's what counts. Besides using just us, there are good machines to measure blood pressure. Direct blood pressure monitors. They are great. What they do is they read obtained information by having a catheter in an artery, facial, oral, sometimes dorsal pedal in larger dogs, and they are then attached to a pressure transistor and monitor. They are by far most commonly used and most applicable in equine practices. Okay, you can use them in small animal practice, medium to large size dogs. It ain't always easy, but you can use it. They are by far the most accurate, and they provide continuous reading throughout the cardiac cycle. If you want the best, most accurate reading of arterial pressure, systolic, diastolic, mean arterial pressure, use a direct blood pressure monitor. Can't use them in cats, can't use them in some medium dogs, little dogs, just can't get an artery, can't get a catheter in that artery. The artery is just too small. Catheters are too big. But from medium-sized dogs on up, especially in horses, it is an excellent indicator of blood pressure. Good stuff. What most of us use are indirect blood pressure monitors, and they really are. They've gotten to be pretty remarkably accurate. You use an external sensor and a cuff. Okay, these are what we use in most practices. They are non-invasive. You don't have to put a catheter in anywhere. You just place your cuff over the appropriate superficial artery, make sure it's where it's supposed to be, right size cuff, and you turn on the machine and start spitting numbers at you. And like I say, the advent of some of the newer, better machines really have produce some good, accurate results. You can also use a Doppler and some other oscillometric methods. I'm not a big fan of Dopplers because that sound they make through the whole surgery drives me absolutely nuts. Okay, but some people love them, and if you don't mind the obnoxious noise, they are a remarkably good way to give you blood pressure monitoring, and they're pretty cheap. Sphygmomanometers, yes, you can just get the old cuffs and you can put them over the artery and you can pump them up, and you can use a stethoscope or watch the little line of mercury go up and down the tube. That is available. Okay, and I've seen people use that, particularly in large animal practices, very accurately. Okay, they can work very well, give you good indirect measurements of blood pressure. Probably one of the most underused methods of measuring blood pressure is central venous pressure. We just don't use it much in veterinary medicine, and that's too bad. What we do is we place a catheter, an indwelling through the needle catheter, into a large central vein, usually the anterior vena cava, going down the jugular. Okay, and you put it in the right jugular vein and send it all the way down as close as you can to the atrium. What you're doing is you're assessing blood pressure, return to the heart, and heart function, especially right-sided heart failure. This is a great technique with patients that are shocky if you need to know how much or how little fluid to give. It is a direct measurement of pressure. You know, you've got a catheter in there. The catheter goes from the anterior jugular vein to the anterior vena cava. It's connected to a water manometer, and you can buy these commercially. They are next to nothing in cost, or you can make them with a meter stick and some IV tubing. How hard is that? And then anywhere from 12 to 15 centimeter water pressure is considered elevated. That means you're giving too much fluids and that you are starting to overhydrate the right atrium, which is going to cause fluid to back up in the lungs, and they're going to drown. Back off. You're going to have to read trends rather than absolute numbers on a one-time basis. You're going to have to turn the little stopcock. You're going to have to read the pressure, turn it off, come back 5 minutes later and check it. Once you've got a good reading and a good baseline, then you can check it, depending on circumstances, every 5, 10, 15 minutes. But you are going to need to check it periodically. It can tell you if the patient is hypofluidized. I guess there's not a word for that. If they're receiving too little or too much fluids. Okay. If the CVP goes down too far, they need more fluids. If the CVP goes up too high, they're getting too many. And it's a great way of preventing overhydration or underhydration, especially of shocky or of very sick patients.